صباح الخير. موضوعنا النهاردة إن شاء الله عن المال absorption. 72-hour fecal fat test. A patient should eat about 100 gram of fat, which is equivalent to half a stick of butter, margarine per day for 4 to 6 days. We collect stool for the last 3 days in a tightly sealed container and assay for total stool weight and fat content. Normally, it is less than 7 grams per day. Xylose test. Xylose is a monosaccharide used to measure mucosal absorption of sugar. Administered to 25 grams orally, and draw blood sample at 2 hours. Collect urine for 5 hours. Analyze xylose in blood and urine. Along with the 25 grams of the xylose consumed, 50% excreted through GIT and 50% will be absorbed in the gut. 25% of these undergo hepatic metabolism and 25% released into the general circulation. Here we can measure blood level. Normally it's more than 20 mg per deciliter. Then this amount will be excreted via the kidney, and we collect for 5 hours and measuring a fraction of this ingested dose. Normally it is more than 22% of the ingested amount. Chilling test for vitamin B12 malabsorption. In this test, oral labeled vitamin B12 will be given. This will be absorbed in the terminal area, and part will be absorbed. Part of the absorbed B12 is preferentially taken by the liver to be stored, and the excess is excreted in urine and can be quantitated. So we have to give an IV vitamin B12 to load body stores, and renal function must be good. Urine collected for 24 hours. This test is no longer available, and as no one makes the radio-labeled cobalt anymore. To test carbohydrate malabsorption, we use the hydrogen press test. The principle of test is malabsorbed sugar passes into colon, where bacteria produce hydrogen gas. This gas diffuses into the blood and is excreted by the lung. So, in this test, patient administer 25 to 50 grams of glucose or other sugar orally, and then measure hydrogen in exhaled breath at 2 to 4 hours. We can use other type of sugar to test for specific disaccharides or transporter defect, as in case of lactase deficiency or glucose-galactose malabsorption. When we do test for malabsorption, we can interpret this test in the form of: if there is a fat malabsorption only, we can suspect luminal maldigestion, example pancreatic insufficiency or bile salt deficiency. If we find plus fat malabsorption, B12 malabsorption, luminal maldigestion due to ileal loss of bile salt and bile salt deficiency may be suspected. For example, diseases which can cause this defect: bacterial overgrowth, which deconjugate bile acid, and bacterial uptake of B12. Another finding is specific disaccharide malabsorption. If it is found, it means mucosal maldigestion, example disaccharidase deficiencies. If fat and xylose malabsorption plus or minus B12 malabsorption, this means mucosal malabsorption due to mucosal disease such as in celiac sprue, tropical sprue, bacterial overgrowth, severe Crohn's disease, or Weber disease. Lastly, tool for evaluation of malabsorption: diagnosis of underlying disease. Once we have identified a small group of possible disease, we can do radiograph of small bowel to delineate anatomy, endoscopic retrograde cholangiography ERCP to define the anatomy of biliary and pancreatic duct, pancreatic secretory function test, small bowel biopsy and or antibody test for celiac sprue, quantitative small bowel bacterial culture, bile acid or glucose press test for bacterial overgrowth. So we can classify causes of intestinal malabsorption into disease in which impaired intraluminal digestion is dominant. Example, pancreatic disease, hepatobiliary disease, post-gastrectomy malabsorption. Second one is disease and syndrome in which both impaired intraluminal digestion and the mucosal function are often operate. Example, intestinal bacterial overgrowth, short bowel syndrome, gastrinoma, Zollinger-Ellison syndrome. The third one is the diseases or syndrome in which impaired postmucosal transport is dominant, like primary intestinal lymphangiectasia or secondary intestinal lymphangiectasia. This table shows some diseases in which impaired mucosal digestion, uptake, and the transport are dominant. The commonest of which is celiac sprue. Others is refractory sprue, immunoproliferative small intestinal disease, and the lymphoma, tropical sprue, eosinophilic gastritis, systemic mastocytosis, radiation enteritis, amyloidosis, Weber disease, Crohn's disease, abetalipoproteinemia, parasitic infestation, and lastly carbohydrate intolerance. Then we move to specific conditions resulting in intestinal malabsorption. First of all, disease associated with intraluminal maldigestion like pancreatic and hepatobiliary disease. This is, as we discussed before, due to deficiency of delivery of adequate amount of pancreatic lipase, co-lipase, protease, and amylase, as well as carbohydrate into the proximal intestine are essential for normal intraluminal digestion of dietary lipid, protein, and complex carbohydrate. This element will be discussed in next lecture. Another example of disease associated with intraluminal maldigestion is post-gastrectomy malabsorption. The most common has been termed poor mixing and poor timing. This leads to rapid gastric emptying coupled with decreased release of secretin and cholecystokinin, results in suboptimal exposure of nutrient bolus to both bile salts and pancreatic enzyme as it traverses the small intestine. This is typically occur nowadays due to bariatric surgery, especially sleeve operation. The second category is diseases associated with impaired mucosal absorption and digestion. The commonest example is celiac sprue. Celiac sprue is a T-cell mediated gluten intolerance. In genetically predisposed individual in whom exposure to wheat, barley, or rye induces a characteristic mucosal lesion that respond to dietary gluten withdrawal. Whereas the disease is rare among those of Chinese, Japanese, Korean, and African heritage, it occurs in 0.3 to 1% of the Caucasian of European extraction. Symptoms may initially present in virtually any age, ranging from infancy to late adulthood. Pathogenesis of celiac sprue: ingestion of gliadin, hyaridine, and secalin proteins found in wheat, barley, and rye lead to infiltration of intestinal mucosa with interepithelial CD8 lymphocyte and CD4 lymphocyte in lamina propria, which lead in turn to villus atrophy. So, it is considered as CD4 T-cell mediated disease process. Genetic susceptibility there is a very close association with HLA-DQ2 and less association with HLA-DQ8. This picture shows the pathology of villus atrophy. This one is the normal villi. This one is a normal villi. Here, normal villi. This one is nevilli. So, villus atrophy leading to flattening of the mucosa with loss of villi, together with increased lamina propria lymphocyte. These diagrams show the clinical features of celiac disease. If we start from the mouth, we can find ulcer and tooth enamel erosion. If we go to the stomach effect, the patient may complain of pain and nausea, together with intestinal manifestation, diarrhea, bloating, constipation in rare cases. In a female, infertility, miscarriage, and early menopause can occur, together with skin manifestation, brittle nail, acne or eczema, joint and muscle pain and swelling, lactose intolerance, anemia, dizziness, migraine, depression, low vitamin D, chronic fatigue. Test to confirm celiac spore diagnosis. Uh, First of all, positive specific blood test like TTG, tissue transglutaminase antibody, or EMA endothelial antibody. A serology less reliable in a young baby less than 5 years old. Then the best is abnormal biopsy of a small bowel by endoscopy. We show villus planting or atrophy, crypt hyperplasia, intraepithelial lymphocyte. The disease show patch distribution, so multiple biopsy is needed. Symptoms improve on a gluten-free diet, and the normalization of serology and or biopsy occur. In general, prognosis of patients with celiac spore is excellent, but there is a higher incidence of lymphoma, especially of the T cell subtype, among celiac patients who had many years of gluten exposure. In contrast, the incidence is very low if the disease is latent or silent. There is increasing evidence that strict adherence to gluten-free diet substantially reduces the risk of subsequent lymphoma. Screening for lymphoma is not recommended unless suggestive symptoms develop. Weber disease is another example of a mucosal disease causing malabsorption. It is easy to diagnose and easy to treat if you think of it. So, in this disease, malabsorption, together with malabsorption and diarrhea, steatorrhea, there is arthritis, lymphadenopathy, and maybe encephalopathy. Intestinal biopsy show together with villus atrophy, there's a bacteria leading macrophage and lipid pool in the mucosa. Staining of these bacteria with periodic acid chief stain. This type of bacteria is Treponema webeli bacilli. Another example of specific disease causing malabsorption is a small intestinal bacterial overgrowth. There is 1 to 10 trillion bacteria in our intestinal tract, most of which are in the large intestine. When they are overgrown in the small intestine, digestion and absorption are disturbed. Because the small intestine is such an important part of our digestive system, overgrowth can set the stage for a number of acute and chronic conditions. Normal intestinal peristalsis and sphincter function should move ingested food together with the bacteria from the upper digestive tract into the large intestine. Failure to move the bacterial along will allow them to become established and causing the symptoms. Causes of this overgrowth may be obstruction, sluggish peristalsis, intestinal neuropathy, diverticuly in small intestine, failure of sphincter valve function. Symptoms of bacterial overgrowth: food allergy and intolerance, joint ache and muscle pain, mood swing, episodic brain fog, weight loss, deficiency disease, gas, bloating, constipation, diarrhea, fatigue, immune system dysfunction. Diagnosis by vaginal aspiration or lactose hydrogen test. Other link, treatment is by massage, probiotic, antibiotic, avoid sweet peppermint oil, exercise, and etc. Another example is tropical sprue. The tropical sprue occur among natives of visitor to selected countries located between the Tropic of Cancer and the Tropic of Caribbean. Major epidemics have been described in South Indian village, and sporadic cases seen in the United States are largely among immigrant and returning tourists and visitors from the Caribbean or tropical Asia. The causes of tropical sprue remain obscure, but its epidemiology and its response to antibiotic therapy strongly suggest that colonization of the intestine by an infectious agent or alteration in the intestinal bacterial flora induced by the exposure to another environmental agent is important. It must be stressed that no single causative agent has been identified. Please remember that celiac sprue, with its characteristic but not specific small bowel mucosal lesion and its clinical response to gluten withdrawal. Tropical sprue with appropriate geographic exposure and response to antibiotic and folate. Weevil disease with demonstration of Cerifluema weevillei and characteristic periodic acid chief positive macrophage and intestinal mucosa. Small intestinal bacterial overgrowth document evidence of malabsorption plus positive breast test lactulose glucose response to antibiotic. Before goodbye, please be ready with your questions in the next face-to-face session.